Hello. Let's talk about this SDL titled Inflammatory Bowel Disease. This is kind of a black or white, either or type of SDL. You got heads and tails, you got Crohn's and ulcerative colitis. So there is a lot to know to differentiate the two of them. You can differentiate them at a lot of different levels of analysis, from the gross morphology to the histology to the complications downstream and the biochemical mechanisms underlying each disease. There's a lot of differences. First Aid summarizes this very well. I encourage you to just take this table and fold a paper hot dog style, right? And then just copy it down and do that 2 or 3 times, and you're going to know CD and UC. As for the test questions, I think it's highly likely you get one about the types of T cells involved in each response, Th1 for Crohn's disease, Th2 for ulcerative colitis. And Th1 I think of as the cell that kills other cells. And Th2 is kind of an area of effect cell, kind of like a bomb in Legend of Zelda versus a bow and arrow, right? The bow and arrow is going to smack one enemy, but the bomb can potentially hit multiple enemies. And so that's the humoral immunity, that area immunity that you're upregulating whenever you make a bunch of Th2 cells. And so there are different cytokines involved with getting the ball rolling on either of those two respective pathways. Just know off the bat that Crohn's involves that Th1 response and UC involves that Th2 response. In terms of other good questions, the complications of Crohn's are a little bit different from the complications of UC. Crohn's can lead to vitamin malabsorption, which you are not going to see in colitis because that only involves the colon and you are not absorbing any vitamins in your large intestine. So that whole malabsorption associated with CD opens the door to a lot of questions there. Toxic megacolon is a big risk of ulcerative colitis. And then finally, off the top of my head, fistulae and sinus tracts are very, very predominant complications in Crohn's disease, but you very rarely see them in ulcerative colitis. The reason being that Crohn's disease has inflammation that buries very deep into the wall of the gut, and we're going to call it a transmural inflammation because it even ulcerates through the muscularis propria layer of the gut wall. So because UC doesn't do that, we really don't see fistulae with ulcerative colitis. Then finally, there are some extraintestinal manifestations of either of these two diseases, and the correlates are largely going to be to the seronegative spondyloarthropathies. So I could see a question being pulled out of there because there are a couple different types of seronegative spondyloarthropathy. So first of all, what's a seronegative spondyloarthropathy? Well, it's basically arthritis without rheumatoid factor. So what's rheumatoid factor? Good question. It's a specific autoimmune immunoglobulin against the FC region of IgG. And the FC region is on the constant fragment of IgG, not the variable. So the FC region is responsible for binding to immune cell receptors and binding to complement after immunoglobulin G has been activated. And so as you can imagine, you've got a lot of IgG in your blood. And if you have this rheumatoid factor, which is an antibody against IgG, then you're going to develop some immune complexes, which are these insoluble proteins that float around in the bloodstream and like to deposit in the walls of your microvasculature. And so that capillary deposition of immune complexes is a traditional type 3 hypersensitivity vasculitis. So when you get the vasculitis, well, when that happens in a joint, you get the arthritis, right? And then that's why you see rashes associated with joint pain and arthralgias in a lot of conditions, including rheumatoid, psoriatic arthritis, ankylosing spondylitis, but even more systemic autoimmunities like lupus, you get to see a petechial rash too, and it's the immune complexes that are giving you that rash. So that's the main questions that I can pick out of here. Other than that, if you learn, again, that one table in first aid, Crohn's on the left, UC on the right, you learn that table, you're going to be good to go. So let's get into this text. Talking about the anatomy of the large intestine, we know what that looks like. talking about the histology of the large intestine. And so for those of you who are still kind of up in the air about, is this colon, is this small intestine that I'm looking at, the way that I think of it is hold up your hands in front of your face. Your small intestine histologically looks like if your fingers are all spread out. And then your large intestine histologically looks like if your fingers are all smushed together like this, okay? So you're going to see glands, and they're going to be long tubular glands shaped like a chemistry test tube. You're going to see those sorts of glands in both. But you see villi in small intestines, and villi have separation between them. Like when you're holding your fingers up, you've got spaces in between your fingers. But when you press your fingers together, that's representative of the lamina propria in between different individual mucosal glands of the colon. So it's a columnar epithelium with colonocytes, absorptive cells, and lots of goblet cells as well. Those are the little poofed up globules that you're seeing in the mucosa here. And then down at the bases of the crypts of your colonic glands, you have enteroendocrine cells, Paneth cells, which play a role in host defense, and stem cells, which regenerate the colonic mucosa at a timeline of about 3 to 7 days turnover. Inflammatory bowel disease is idiopathic, meaning we're not sure exactly what causes it. We're idiots, basically. It involves an immune reaction of the body to its own GI tract, so both Crohn's and UC, the body's reacting against its own gut. Now, ulcerative colitis characteristically is limited to the colon and the rectum. That's big. Crohn's disease, you might see that in the colon, you might see it in the rectum, but you're usually going to see it in the small intestine as well. And so if the small bowel is involved, you've got Crohn's disease on your hands. You don't have UC. Histologically, I suppose morphologically too, ulcerative colitis only extends into the mucosa and submucosal layers of the gut wall. Crohn's disease, however, is typically transmural, meaning ulcerations become so severe that they just burn through the entirety of the gut wall. It's not contained. And then there's your introduction. You can see joint involvement, skin rashes, eye problems, hepatobiliary stones associated with CD and UC. Then we briefly touch on the therapy. If either of these get bad enough, surgical resection of the affected bowel comes into play. For ulcerative colitis, we take the whole colon out, and that's usually curative because, again, you're not going to see this autoimmunity involved in UC up in the small gut. So patient doesn't have their autoimmunity anymore, really. However, surgical intervention is not curative for Crohn's disease, and the guts that you leave in the person when you take out or resect a stretch of bowel for a Crohn's disease patient, the GI tract that they still have left in them after that resection can develop Crohn's disease once more. It's got a slight bimodal onset. The majority of cases for inflammatory bowel disease present in young adulthood, late teens to young adulthood, and then there's a second smaller peak in the elderly. So what gives you inflammatory bowel disease, or what's the trigger rather, because it's an autoimmunity, and all autoimmunities have some sort of triggering event that just gets the snowball rolling downhill. Well, we really think that in terms of genes, it might be related to, and I'm skipping ahead a little bit, junctional complexes that hold enterocytes together, that basically glue them in place. And some sort of looseness in these junctional complexes, or maybe it's an autoimmunity against these junctional complexes themselves, makes your gut mucosa a little bit more prone to local infection. And so over time, that creates the ulcerations that are characteristic of both Crohn's and ulcerative colitis. Back up to environmental triggers. These aren't causative agents, but rather things that kind of speed up the autoimmune progression a little bit. Developed countries have higher incidences of IBD. It's a disease of hygiene. It's a disease of cleanliness, similarly to asthma, many atopes, which are specific allergies, and multiple sclerosis, rheumatoid arthritis. All of those are diseases that you're more likely to get if your mom didn't let you play outside when you were a kid. Poor sanitation appears to be protective against inflammatory bowel disease, and that's probably reflective of the diversity of the gut microbiome if you live in such conditions. They're more common in white-collar jobs, although that's not, in my mind, necessarily a risk factor you're going to get tested on. And if you smoke, you're more likely to get Crohn's, but you're less likely to get ulcerative colitis. That's a pretty particular finding, so you should be able to remember that for a while. And zooming back in, looking at the genes involved, there is a familial component, which is how we know there is a genetic component, because we know you can inherit inflammatory bowel disease, both Crohn's and ulcerative colitis. We have identified NOD2 as a susceptibility gene for Crohn's disease, and NOD2 is a nucleotide oligo something binding domain that's going to essentially recognize pathogens and put them on the surface of the cell to trigger an immune response. And we've seen NOD-like receptors before, way back in our Block 1 immunology courses. Here's a slide showing you what they look like. Very similar shape to that toll-like receptor that's always extracellular, or some TLRs are intracellular, but NOD-like receptors are always cytosolic. And so they're going to recognize maybe peptidoglycan from the cell wall of a bacteria after it's been phagocytosed by a particular cell, or after the breakdown products make their way intracellularly into the cytoplasm of an enterocyte or an immune cell. And so these NOD-like receptors are then going to take the peptidoglycans that happen to randomly bind to them, and they're going to localize to the surface and present those antigens to immune cells, and that's going to get the ball rolling on an immune response. And so macrophages are going to come in, and maybe if this is happening inside a macrophage, maybe get a T cell response particular to the specific antigen. So that's a NOD-like receptor, and it's linked to Crohn's disease. Back to pathogenesis, we don't see colitis in animals with sterile bowels, and that's pretty important because we know that it's got to be some sort of external factor that is triggering an autoimmunity within ourselves. Because again, if you keep an animal sterile from birth and you let it grow up, and even if it has all these susceptibility genes, it's still not going to develop colitis. So we know it's related to the gut microbiome. Back again to what we mentioned earlier, IBD biopsies have demonstrated downregulation of E-cadherin and beta-catenin. And so that's also what predisposes IBD patients to developing colorectal cancers at higher rates than the general populations, especially in ulcerative colitis, because that E-cadherin beta-catenin pathway is regulated by APC. The APC gene, if you lose it, allows for unimpeded cell growth. And so if you have downregulated E-cadherin beta-catenin, what that's telling me is that they're all translocated to the nucleus and binding to their promoter site. Or if you don't have them at all, then maybe that promoter site's just constantly active. Another little blurb saying that exposure to commensal bacteria in normal individuals downregulates inflammatory genes. So what this essentially means is that whatever bacteria is in your gut normally, you've got a tolerance to, meaning this whole NOD-like receptor pathway that we just looked at, that NOD-like receptor does not activate whenever components or little pieces of commensal bacteria are presented to your immune cells. They're just going to say, oh, no, those are friendly. Nothing to see here. No immune response here. So you've got this very complex tolerance built up to commensal bacteria. But if the proportions of different bacteria in your gut are changed, or if there's an invasive species introduced, that can be the trigger, we believe, which is going to start the progression of IBD. So that's what that paragraph is saying. And then a description, good descriptive sentence: patients with IBD have excessive immune cell recruitment and activation and abnormally increased secretion of inflammatory cytokines. What does that mean? That means that the immune response is almost always there. So that means that either it's an autoimmunity or the instigating agent, the stimulus, is always there, which is why we think it's bacterially related. And I threw in a note: remember that you need interleukin 10 to shut off inflammation, and it attenuates, IL-10 attenuates inflammation, it stops it. So if you don't have a proper IL-10 response, if maybe you've got a defective gene, one copy of that, then you're going to be more prone to develop IBD. And at the bottom of page 5, this is really where my test question alarm is going off with the Th1 and Th2 responses, because they are characteristic of Crohn's, the Th1, and ulcerative colitis, the Th2 response. And there are various cytokines involved with each, and I don't think you'll have to know them, but if you want to brush up on them, this is a good opportunity to do so right here. No single organism has been conclusively associated with inflammatory bowel disease. However, we're suspecting things like Clostridium, E. coli, Listeria, Campylobacter, MAC, Mycobacterium avium. What all those things have in common: they like to get down in your gut. Various viruses too can cause upset stomach, GI flare-ups, including CMV, especially in transplant patients, and measles, especially in children. You can see an upset stomach with those. So we think it's tied to a sickness or sicknesses. We just don't know how yet. The pathogenesis, you know what the inflammatory process is. There's some cellular damage, and the oxidative species associated with that damage, as well as the damaging antigens, if there are any in the area, are going to activate local epithelial cells to generate cytokines, which attract neutrophils through vasodilation to come and clean up the damage. And if neutrophils can't do it, you get macrophages and lymphocytes involved. That's inflammation. That's what's going on in both copies of IBD. And there's a good amount here on cytokines. Again, if you would like to brush up on that, that's a great paragraph to read to remind you what certain things like IL-12 do. The T helper 1 and the T helper 2 response are touched on here, but not really in depth. I think the big point to remember is that Th1's typically a cellular immunity route, and Th2 is typically more of that humoral area of effect immunity. So now we get to the good stuff. Let's talk about Crohn's disease. How does this present? Well, they both present pretty similarly. Diarrhea is a symptom common to Crohn and UC, but particular to Crohn, you might see non-bloody diarrhea with this crampy, colicky abdominal pain. And colicky pain is always due to some sort of obstruction. You can see colicky pain with a gallbladder obstruction or a bile duct stone, right? Because that also contracts and puts stuff out into the lumen. And the gist of colicky pain is that you've got, I'll draw this out for a little bit here. You've got a tube that you're trying to push something through. And at a certain part of the tube, there's a stenosis or a narrowing of the tube. And so whenever what you're trying to push through the tube gets to this narrow point, it just can't go on anymore. And so when you're pushing against that obstruction, that's what generates the colicky pain, because you can't pass this thing through, and all the nerves in the area are just enraged because they're stretched for a long time. And then that irritation signals to your brain, hey, there's something going on here. And so colicky pain, how do you recognize this clinically? It's pain that's intermittent. It's going to be there, and then it's going to be gone. And then it's going to be there, and then it's going to be gone. And then it's going to be there, and then it's going to be gone. And so the reason why you might see like a left lower quadrant, right, or a periumbilical colicky pain is going to be because of a stricture that could give you a direct obstruction to the flow of stool through the bowel. And every time your bowel contracts around that stricture, patient feels pain. But when the bowel relaxes, patient's pain lets up. They feel a little bit better. But because your bowel has a slow wave that's always going through it, and a migrating motor complex, right, that's interdigestive, that means that every, 30 seconds or maybe 10 seconds or so, depending on where you're at in the gut, you're going to get a contraction. So when you get that contraction and there's an obstruction, i.e. a stricture, you're getting this colicky pain. Crohn's disease, diarrhea without bleeding. You can get bleeding. You can have a hemorrhagic ulcer. You can have a GI bleed as a result of Crohn's. But in test questions, if you see bleeding, they want you to think colitis. Malabsorption is a symptom particular to Crohn's disease because it involves the ileum. And a lot of stuff gets involved with your ileum. It might involve the jejunum as well. And so that's why you can see a B12 malabsorption, any B vitamin malabsorption. You could see hypoalbuminemia because you do absorb protein in the small intestine as well. And you could see a steatorrhea due to too much fat being left in the gut lumen because you can't absorb it, because that also gets absorbed in the ileum. And then finally, if your ileum is getting just wiped out by ulcers, if it's bad, well, what else related to fats gets absorbed in the terminal ileum? Bile salts. So that's another thing giving you fat malabsorption that way. Complications of Crohn's disease. Perforation. It's not specific to CD. You can see that in ulcerative colitis as well, that perforation. But it's more common in CD. And what's really particular to Crohn's disease are fistulae. So to understand how a fistula forms, you got to understand what a stricture is. And a stricture is described up here at the lower part of page 6. I'm going to read you what the text says, and then I'll give you my interpretation of it. The transmural nature of the inflammatory process in Crohn's disease results in fibrotic strictures. Strictures often lead to repeated episodes of small bowel obstruction. So what a stricture is essentially a scar tissue constriction. I want you to say that. Say scar tissue constriction. Stricture, scar tissue constriction. And what it's going to do is it's going to constrict the lumen of the gut. Constrict. What does that mean? Well, vasoconstriction. The thing pinches off. It gets smaller. The lumen closes. It tightens. Same thing in the gut. We've seen esophageal strictures already. How do you get strictures in the esophagus? GERD. So there's damage of the lower esophagus, and that damage stacks up over time. And every time there's damage, some cells just die off, and in their place, the surrounding cells throw collagen down. That's the scar tissue component. So you have that happen enough times, and eventually, well, half of the lumen of the esophagus at a particular point along its length is just going to be scar tissue. Same thing in the gut. You have some sort of obstruction, like we've illustrated in the lower left there. Well, maybe the obstruction passes, but let's say next time you have a bowel movement come through, there's another obstruction. Every little obstruction there is stretching and increasing the pressure within that GI lumen, and it's really irritating cells. And so maybe you lose a couple of cells every single time there's an obstruction, but that adds up, and over time it just gets worse and worse and worse, and there's more and more and more scar tissue thrown down in the area as the body's attempt to hold itself together in the face of this injurious stimulus. So I've mapped out a timeline generally of these strictures on this one slide, and I've also shown you what they look like here. So first you get some sort of inflammation. We said in the esophagus, that's GERD. Well, in inflammatory bowel disease, it's autoimmune. And we don't know how it's autoimmune, but we know that it's autoimmune. We know that what gets the ball rolling is an autoimmunity. So there's some inflammation, some cells are dying, some colonocytes specifically, and in response to that, you're going to scar up that area where there's cell death. But the problem is that anywhere you scar is going to be mechanically weak because it's not made of real cells, It's just a patch, like on a portion of drywall, you know, that patch is a lot thinner than the actual drywall around it. And so because you've got this mechanical weakness, well, that patch also can't move like cells can. Scar tissue is very immobile and fixed in its ways. And so whenever you go to pass some poop through a scarred stretch of the GI tract, it's a little bit tougher to pass it through that scarred area. And so what does that do? Well, that creates even more inflammation and even more scarring because it's already narrowed, and so the pressures are higher and the cells don't like that. So over time you do get this impaired peristalsis and this pressure buildup associated with that narrowing of the lumen and that failure of the lumen to move because of the scar tissue. And if this stacks up enough, what is it going to lead to? A perforation. If you go to I don't know, what's your favorite place to eat? If you eat a giant meal there, you know, that's going to be the stimulus for a perforation of a weak spot of your wall. If you already have this inflammation-mediated scarring there. So in my case, you know, I love to just get a pack of like 12 chicken thighs and just eat them all. Or I love to just get like a pound of ground beef and then just like eat a whole pound of ground beef and then maybe like another pound like 2 hours later. So if you got a giant meal like that just rolling through your gut and you already have this autoimmune mediated scarring, bang, there's your fistula. Because if the meal's big enough, the pressure gets high enough inside your gut that weak spot, the patch in the drywall, just ruptures, it pops. And so we'll use some True Blue. That's where it happens. And it creates this little tunnel and it eventually gets bigger and bigger and bigger, and it can wind up perforating the entire length of the wall. We could call that a fistula. And if we're going to call it a fistula if it connects to another organ. But don't get the fistula, the tunnel, confused with the stricture, which in green is just the constriction of the lumen of the gut. Top right, there's your stricture in green, right? That spot where the wall is thickened. Why is the wall thickened? Damage. Why is the wall being damaged? Well, if we're talking about IBD, it's autoimmune. And then, do you see that where this wall is damaged, do you see that the lumen is narrower right there where the stricture is? Ah, yes. So that's how you get the fistula, because the pressure builds up where the lumen is more narrow. And the lumen is more narrow because of the scarring, and the scarring's there because of the autoimmunity. So that's how you get the fistula in Crohn's disease. And the fistula can get infected very bad, and you can see an abscess pop up out of that fistula. Or again, that's if it's blind-ended. You could see the fistula just totally connect to a different stretch of the gut like it is in this picture here. Notice that that's a fistula between two non-adjacent parts of the small bowel. Or you could even get a fistula like right here between the small bowel and the colon. Okay, so you could get a fistula between the colon and the bladder. You could get a fistula between the anus and the outside world. You know, it could drain through some anal glands and out the skin. So lots of different directions this concept of fistulation could go in on an exam question. So you need to make sure that you know what's happening with the fistula. You need to know that there's this stricture that leads to a fistula, and there's this scarring that leads to a stricture. And if you understand that, you understand this whole SDL, and the rest of it's just memorization. I'm dead serious. The rest of it is make a table, copy it once or twice, do some Anki, and you're done. Because this is not a difficult pathology to discuss. So in Crohn's disease, you see skip lesions. And what does that mean? It means you got a lesion here and a lesion there. Maybe like spots on a Dalmatian is another way to look at it. And this is compared to ulcerative colitis, which is always going to be one big, long, continuous lesion. Not too hard. And the terminal ileum, that last segment of small bowel, is involved in roughly 70 to 80% of Crohn's disease cases, and that's going to help you make a diagnosis. Now, these ulcers have been described in Crohn's disease as serpentine and elongated, long and skinny. And again, they're going to be patchy. And in between two ulcers, the tissue might be hypertrophically, hyperplastically raised up and elevated. And so it's going to have a cobblestone appearance, very similar to how the kidney takes on a cobblestone appearance in hyaline arteriolosclerosis, correct? When you start popping off the microvasculature of the kidneys and you start losing glomeruli, the rest of them are going to swell up to kind of pick up the slack for that dead tissue. So same thing's going on in the gut here. That's your cobblestone appearance. Strictures in the terminal ileum are classic. Again, what does a stricture look like? It's that narrowing of the lumen, and it's mediated by scar tissue that gets thrown down in response to the autoimmunity. So in Crohn's disease, the intestinal wall is thick and rubbery as a consequence of transmural inflammatory edema, submucosal fibrosis, and hypertrophy of the muscularis propria, all of which contribute to stricture formation. So that transmural edema and that muscularis propria hypertrophy are two big predisposing factors to getting a bad stricture, not just a little bit of a stricture, but like a stricture that really does obstruct the bowel. A good page full of images. Here we're seeing some patchy lesions. There's a lesion, there's a lesion, there's a lesion right there, and then there's a lesion right there. And so you see they're not kind of connected with one another. It's more so that like they're a string of dots, like a dotted line. This is this phenomenon called creeping fat. And so when you're thinking about creeping fat, you want to think about a gut that's been sliced axially. So imagine you're looking down the z-axis of the gut and you're looking at a lumen like that. Well, normally you've got mesenteric fat just kind of around where the mesentery attaches to the gut, but you don't have that much of it, you know? So with creeping fat, the fat creeps down and wraps around a larger circumference of the overall bowel, eventually to the point where it's just surrounded by fat. And so that's abnormal. So if you get shown a gross picture of a bowel that is almost 100% encased in fat, that's what's going on. It's that creeping fat phenomenon, and it's mesenteric fat, and it's particular to Crohn's disease, not UC. Something else that is particular to Crohn's disease is the non-caseating granuloma. Now, I want to make a big point right here. This crypt abscess that is on the right-hand side of these middle two photos, that's non-specific. You can get a crypt abscess in Crohn's disease. You can get a crypt abscess in ulcerative colitis. So you see one of those, you're thinking IBD, but that doesn't make the diagnosis for you. However, you see one of these granulomas, and that is Crohn's disease. No doubt in your mind that's Crohn's. And the way to tell them apart is you're looking at a crypt abscess. Well, it's a crypt abscess. It's within a glandular crypt, and you can tell it's within a gland because there's the lumen, duh, going all the way around that abscess. So you see a nice cuboidal epithelial circle around those crypt abscesses versus a granuloma. You don't see a lumen around that. That's a submucosal structure, or rather, that's a mucosal structure in the lamina propria of that mucosa. So what type of cells are those inside the granuloma? They're macrophages. I really hope you said macrophages. Now, what cell makes those macrophages do that? And the answer is typically the Th1 cell. Ah, there we go. So you get a Th1 helper T cell that's making lots of interferon gamma. And interferon gamma just makes macrophages go wild. Just crazy, yo. And so when they do that, they form this big clump and they start to make epithelioid cells, and then they start to synthesize and make giant cells by joining together. Last couple images, they're gross. This is a transmural ulceration. They're trying to get you to understand that. But I don't think that's something that you'll be tested on acutely, presently, on our in-house exams, just based on, hey, is this transmural or not? Because it's like, we're not pathologists. Patchy distribution, Crohn's disease. Abundant neutrophils, non-specific. You're going to see that in UC as well. Crypt abscesses, non-specific. You're going to see it in UC as well. Transmural inflammation, focus on that. That's Crohn's disease. Th1 instigated non-caseating granulomas comprised of macrophages activated by interferon gamma. That's Crohn's disease. I don't know why this STL says Crohn disease and not Crohn's, you know, with an apostrophe S. I mean, Lord, I Wikipedia the thing and it says Crohn apostrophe S. Really throwing me for a loop, you know? So this table, know the table, just know it. Just know it. Do what you have to do. You know, don't tell me what it is. Some of you do some dark things to memorize facts. Just go into your chamber or your lair or your basement or wherever you dwell on such medicinal matters and memorize every single word of this table. That's my best advice. Ulcerative colitis, let's talk about it a little bit now. Presents very similarly to Crohn's disease. However, hematochezia, bloody diarrhea, dysentery, bloody diarrhea, that's going to be the hallmark of the disease symptomatically compared to Crohn's. Also, patients are most of the time going to say it's my left lower quadrant that's hurting. Now, they're not going to say it's my left lower quadrant, but they're going to point down there. And then the question stem will say left lower quadrant. So you're going to be like, oh, okay, large bowel's involved. We brought up before, a colectomy, taking the colon out, is curative for ulcerative colitis, but not for Crohn's. And then this sentence brings up a great point. Extraintestinal manifestations may persist even after you resect the colon in ulcerative colitis. And we'll talk about those in a little bit. Just remember that, I mean, I could see a question popping out of that. Oh, patient's got ulcerative colitis. They just tell you that. And, oh, patient just has a colectomy. And they give you that one too. And then it's like question related to reactive arthritis, you know, something like that. So ulcerative colitis always involves the rectum and extends proximally in a continuous fashion to involve part of the entire colon, part or the entire colon. Skip lesions are not seen. So that's the question stem. And they're not going to ask you about ulcerative colitis without telling you, oh, it's starting at the rectum and proceeding upwards, you know? Or like, oh, it's not in the small intestine. Or, oh, it's one continuous lesion. They have to tell you something like that. Otherwise, you have no clue what the diagnosis is. There can be an abrupt transition between diseased and uninvolved colon, which is what we're looking at here. There's your transition. Again, that's very distinct, well demarcated. And you could see colonic polyps. And again, remember we said E-cadherin, beta-catenin can be involved. And so those are the same genes involved in our polyps and possibly even carcinomas of the colorectal GI tract. And those genes are going to be APC. You're going to see Wnt, that pathway. KRAS is involved as well. That's an oncogene that typically gets mutated after the APC mutation. And then you get a P53 mutation after that, right? And then alternatively, you could go through the microsatellite instability mutation pathway involving things like MSH1, MLH2, Lynch syndrome. So big correlate, much more so with ulcerative colitis than Crohn's, big correlate with colorectal cancer. Now, histologic features of mucosal disease and ulcerative colitis are similar to Crohn's disease presenting in the large bowel. However, the inflammatory process is diffuse and generally limited to the mucosa. Now, I don't think they'd give you that because then they'd specifically, like, it's too convoluted, you know, and people go to school for 5 more years before they are allowed to make this diagnosis in practice, you know. So I feel as though they're going to equip you with a lot of clues to make your diagnosis beyond just the histopath, which is why we're not focusing on that as heavily today. The muscularis propria is rarely involved. Again, you don't even have to be able to read histology to understand that, you know. It's going to be apparent, and they're probably going to tell you with words. Granulomas are not present in ulcerative colitis. Fistulas and abscesses do not occur. So again, part of one of the 5 questions, Tims, that you get from this test is going to involve an IBD lesion with a fistula or an abscess. And you're going to have to say that is not ulcerative colitis. Laboratory studies in IBD. So we're done with UC. We're talking about both of them in general now. In general, anemia is very common because UC likes to bleed, and Crohn's likes to have that iron deficiency due to malabsorption. You can also get anemia due to B12 or B9 deficiency. That would be a macrocytic megaloblastic anemia versus a microcytic small cell anemia with your iron deficiency. You're going to see a peripheral leukocytosis. You're going to see elevated CRP and SED rate, and you can commonly see low blood protein, low protein intake due to that malabsorption as well. And so anemia, vitamins, protein, going to be the first things that you're looking for if this is a first-time patient complaining of these symptoms, because those are correctable deficiencies. Serologic markers. This is going to be part of one question stem on at least one question. This might actually be what gets asked. They might say, what would you see in the blood of this patient? And you're going to have to remember that P-ANCA is associated with ulcerative colitis, and that ASCA is associated with Crohn's disease. Yeah, that's it. It's that easy. Off the top, granulomatosis, polyangiitis, GPA, remember, that pulmonary renal syndrome. You see granulomas in the lungs and in the kidneys and up in your nasopharynx as well. That's associated with P-ANCA, just in case they want to pull that. What other disease has the similar finding question on us? There's extensive overlap between the 2 types of IBD. Definitive diagnosis is not possible in 10% of these patients, and we're going to call those cases indeterminate colitis until we get a little bit more clues. Colitis-associated neoplasia, again, more common with ulcerative colitis than Crohn's disease, and commonly involves APC, P53, and KRAS. That's your chromosomal instability pathway. And it can also involve MSH2. And if you see that in the question stem, you're thinking microsatellite instability. Extraintestinal manifestations. So let's take a good look at these and talk them through, because there are a good 2 handfuls of them, I feel like. And because telling the 2 apart, quite frankly, UC and CD is so easy, I feel like they want to ask us something that's a little tertiary to the initial diagnosis, and this could be it. So 20 to 40% of patients have extra gut manifestations. The most common is going to be arthropathies and arthritis. Arthritis associated with IBD is considered part of the seronegative spondyloarthropathies, which can present as an oligoarthritis affecting large joints, can present as a symmetrical small joint polyarthritis. Antinuclear antibodies and RF are usually absent, and that's again what makes it a seronegative spondyloarthropathy. There's nothing in the blood, seronegative. It's not gonococcal arthritis, because you might get a fluid draw from the joint and it's totally sterile. Sacroiliitis and ankylosing spondylitis. So there, again, sacroiliitis, it's obviously going to be pain of the sacral bone where it meets the crests of your hip bone. and ankylosing spondylitis. That's going to be the lower spine, the lumbar spine that's involved there. And so patients are going to have, I suppose, hypogastric pain. And it's going to be deep, and they're going to just complain of arthritis. Basically, it's typically young men, and they typically have this HLA-B27 haplotype. So things that we mentioned at the start of the video: you don't have rheumatoid factor. Rheumatoid factor is an antibody against IgG, against that constant region of IgG, so against like all IgGs that you make. And you get a type 3 hypersensitivity when that rheumatoid factor IgG complex sticks in the walls of capillaries. Skin manifestations. Erythema nodosum is one. Erythema nodosum might be, there's a couple fungal infections associated with that. I'm thinking histoplasma and coccidioides. You can get an erythema nodosum. And what does it look like? Bunch of dime-sized red bumps on the legs, and they're painful, and you get them on your shins. Pyoderma gangrenosum. So when we see pyo, we're thinking neutrophils and a pustular sort of appearance to it. Derma, it's in the skin. Gangrenosum, well, what's gangrene? It's going to be tissue necrosis with a superimposed infection. So not only is tissue dead and necrotic, there's also bacteria there. And so it's obviously going to look pretty messed up. It may span several centimeters in diameter until it ulcerates, and then it may persist for many months before healing. Other skin lesions include psoriasis. You can see a psoriatic arthritis with the HLA-B27 haplotype. And aphthous stomatitis. Where's that? Mucous membranes of the mouth. Ocular manifestations. You see episcleritis, scleritis, and uveitis. So uveitis, well, you put that together with an arthritis, and your patient's practically got Reiter syndrome at that point, especially if you throw in some urinary pain. And so a reminder that some bacteria involved in the development of Reiter syndrome, which is also associated with the HLA-B27 haplotype, are a lot of different enterics such as Shigella, Helicobacter, Yersinia, Campylobacter, and Salmonella. I think chlamydia can give it to you as well. So a very interconnected pattern of extra GI symptomatology in IBD. Hepatobiliary manifestations, usually stones, attributed to the disturbance in the reabsorption of bile salts in Crohn's disease due to terminal ileum involvement. Shouldn't have a hard time remembering that. Finally, nephrolithiasis, so stones in your kidneys as well. And this is also going to be related to fat malabsorption. Now, you can see two types of stones, and I doubt you'll get questioned on it, but I really want to explain to you why you would get oxalate stones from a GI pathology. So oxalate is this really small molecule. It's only got like a handful of carbons on it, and it kind of looks like this. And so normally calcium binds oxalate, and when calcium is bound to oxalate or chelated to it really, you can't absorb either of them, and it just leaves in the stool. So if you have fat malabsorption, it just so happens that small lipids also like to bind calcium and sequester it and keep it from binding to oxalate. So that means more free oxalate when you have fat malabsorption can be absorbed by your body. And oxalate is found in leafy greens and other different plants. It's very high in spinach. And so if you eat a ton of these foods, you're at a higher risk for oxalate stones, and you couple that in with Crohn's disease. And so you get fat malabsorption, fat binds to calcium, calcium can't bind to oxalate. You absorb the oxalate, it goes to your kidneys, it makes a stone. Now you could also see traditional uric acid kidney stones, and that's going to be related to diarrhea associated with IBD. And you should know you see a metabolic acidosis in diarrhea, because whenever you have a repeated diarrhea, well, your body gets a clue that it needs to start trying to conserve sodium and chloride. And so it'll do that by pulling it from the lumen of the gut. And every time you absorb a chloride from certain parts of the gut, you have to kick out of your body a bicarb in order to do so. And so that gradual loss of bicarbonate associated with sodium chloride reabsorption is going to shift the pH of your blood down because there's going to be less bicarb to buffer all of the protons. So that's your acidosis, metabolic acidosis, that can create uric acid stones because uric acid precipitates and crystallizes at a low pH. And alkaline material in the kidneys also helps keep uric acid away from itself. So now let's finish this SDL by brushing on other causes of colitis. There's diversion colitis, which occurs after a colostomy, after a diversion of a part of the gut away and towards the bowel wall. And then you place an ostomy bag, and then you kind of leave the rectum and the anus behind. So the problem when you do that is that this thing can get inflamed too. And this thing can get inflamed through the same autoimmune mechanisms that give you UC or CD to start with, right? So it's not like it's anything new. It's not like the stump is getting stupid infected. No, it's the same autoimmunity, and you just didn't take it out. And it's like, why didn't you take it out, buddy? I don't know. I'm not a surgeon. Colitis can develop within the diverted segment quickly or up to a few years after colonic exclusion. And we think that that rectal stump up here is going to get very irritated because it's no longer seeing short chain fatty acids in the lumen of the gut. So it's essentially losing its energy supply because a lot of those fatty acids that are produced by bacteria through anaerobic fermentation are immediately taken up by colonocytes and then sent through the citric acid cycle to pop out some, acetyl-CoA, which goes through your electron transport chain, and you get ATP that way. So if you're not getting fatty acids from the lumen, you're entirely dependent upon the bloodstream to get your energy. And the blood's not going to try to go down to this rectal stump that has literally no function anymore after you've disconnected it from the bowel in general. So that just leads to its atrophy, and then it's going to swell up as it dies. It might even ulcerate. Irritable bowel syndrome, IBS. What you need to know about this is that it's a clinical diagnosis, meaning lab work's going to be pretty negative. Histology is going to be pretty negative. Endoscopy is going to be pretty negative. Patient's still going to have complaints of abdominal pain or discomfort related to defecation. It's going to get better when they go to the bathroom. And bloating and change in stool frequency are also two key complaints. And remember that there's a spectrum of IBS from the constipated subtype to the diuretic subtype, diarrheal rather. And so some patients have both. And this is the diagnosis that you're going to write down whenever you can't figure out what they actually have, or maybe they don't actually have anything. So IBS is heavily related to psychological stress, anxiety, and anxiolytics are part of the terminal treatment of IBS if the patient wants to go on them. We're also going to treat it with fiber, antidepressants possibly, probiotics, antibiotics. We can throw those at them, see it's worth a shot. And then serotonin agonists and antagonists are used depending on the subtype. Microscopic colitis. Now, this is similarly to IBS, lacking any endoscopic findings. You don't see the ulcerations or the lesions like you see in IBD, but you do see some histologic abnormalities on biopsy. So that's a large part of what sets apart microscopic colitis from irritable bowel. And the other thing that sets apart colitis is that the big complaint here is watery diarrhea, and it can be associated with pain, but really that constant needing to go to the bathroom is the chief presenting symptom here. Now, if you look at histology, we've got normal on the left. You've got two subtypes of this microscopic colitis. You've got one with a ton of intraepithelial lymphocytes. And when we say intraepithelial, we mean that they're literally right there at the top of the mucosa. Or you're going to see this subtype that has a big stretch of collagen, just a continuous band immediately under the surface of the gut mucosa. And we're not sure what causes this. We think that there are some different drugs that play a role, but we definitely think it's got an autoimmune basis, and some conditions related to the development of microscopic colitis include autoimmune thyroid diseases. Graves comes to mind. That's the TSH receptor autoimmunity. Celiac disease, your autoimmunity against tissue transglutaminase, and you make IgA against that. Certain cancers and malignancies, 10% of patients with microscopic colitis have had cancer or have it, and organ transplantation as well. In people with organ transplantations, incidence of microscopic colitis is 50 times fold higher than the general population. That's a lot higher. So again, 2 histological subtypes of this. What's the symptom? Watery diarrhea, always need to go to the bathroom, not associated with pain as much as irritable bowel syndrome. That's if they're talking about pain, okay, moving away from microscopic, moving towards IBS. It's got the histology. For affected patients with microscopic colitis, there's no increased risk of colorectal cancer or development of inflammatory bowel disease. Good news there. Finally, graft versus host disease. Please recall that you can only get graft versus host disease in the setting of T cells being transplanted into you, and the T cells inside the graft are what initiate the GVH response. Most other times, if there's a transplant, you're going to see a host versus graft disease because the host has a lot of T cells that are popping off against the graft, and that's why we keep the host immunosuppressed, is to facilitate the transplantation of one tissue into another. So graft versus the host, as we said, only if you're putting donor T cells inside the host can you see this. So what sort of tissue would have donor T cells in it? The answer to that is bone marrow. It's going to have a ton of them inside of it because that's where T cells are produced, and then they grow up in the thymus, but they're really made in the bone marrow. So acute graft versus host is a reaction of donor T's against GI epithelial cells. You can see it in other organs as well, but if you're specifically talking about GI symptoms, then you know that, again, epithelial cells are involved. Patient's going to present with nausea, vomiting, anorexia, pain, diarrhea, maybe hematochezia, and it's going to be after a transplantation, specifically after a bone marrow transplantation. So this is not going to be a hard diagnosis. They're going to ask you, if they do ask you about this, they're going to ask you about something immunology related or maybe treatment related, or maybe a lead into a micro question because cytomegalovirus is particularly popular in transplantees. So that's IBD. I hope that you at least learned a couple of new things out of that. Again, my highlights, know how to make the diagnosis CD versus UC. And then remember, CD's got a TH1, UC's got a TH2. Use this as an opportunity to brush up on your immunology for about 30 minutes. But other than that, go get it and go learn this stuff.